Hi, I'm Tamara, and this is TELUS Talks with Tamara Taggart. Hi, everyone. Today we are speaking with Dr. Andrew Boozary, who is a primary care physician and the executive director with the University Health Network, the largest research hospital group in Canada. And that includes Toronto General Hospital, which was named among the world's top 10 hospitals by Newsweek magazine in 2019. Dr. Boozary delivers proper health care to people with complex medical and social issues. Thank you so much for being here.
Yeah, thank you so much, Tamara. Really appreciate it.
You know, you have been working on this for a long time. You've been working with people who are homeless, people who don't have access to proper health care. So could you maybe explain a little bit about what are barriers to healthcare? When we hear that in the news, when we hear about people that have barriers to healthcare, what does that mean?
Yeah, no, I mean, I think I appreciate the question, and it's so wide, right? And we talk about the inequities, but when I do think about the conversation about vulnerability, maybe we can start there, to unpack that a little bit about how it kind of intersects with the health system of where we've seen these barriers to access, as you alluded to. I mean, I think the issue with the term vulnerable is, I think, again, that it puts the onus and the deficiency on the individual or the community. And what we have known for decades is that there are certain communities and populations that have been shut out of society, that have been underfunded from public resources. When we talk about things like healthcare resources, public education, transportation, all of the things that we've come to talk about as the social determinants of health in its sort of academic term, but really the things that anyone in any situation would know that can help them attain the life of health that they want. And it's from what you're able to eat or afford to be able to eat, the air you breathe, which neighborhood you live in, the job you have, and all of these other factors that come together in this interplay to really actually have a larger impact on how long someone lives, on the quality of life that someone will have, and those various health outcomes from diabetes to cardiovascular issues to cancer and so forth. So when you go more upstream, you see that we have these social policy decisions that are really shaping people's health outcomes. And then when you come down even a little bit to healthcare access, you're seeing that as well, of for those same individuals and those same communities that have been shut out of some of the social policy measures we've talked about, housing and income supports and access to healthy food and public transportation and walkable space. You also see a really strong divide in who's getting access to certain care. And this almost seems blasphemous for Canadians. We sort of actually had written about it now almost a year ago, actually, of this week, about the mirage of universality. And pre-pandemic, people, it was considered, kind of provocative to say, we have actually continued to punish people living in poverty in the way we deliver healthcare. And that's, again, not just an opinion. That was looking and combing over decades of data of showing certain neighborhoods had worse access to cervical cancer screening, to colorectal cancer screening, to primary care visits, which we know have a very strong foundation for our health system, but also for health outcomes.
When we use language in the media, or when politicians, or public health offices, I should say, are using language like, we lost, we're losing people with underlying health conditions. Does that send a message to somebody like me who doesn't have an underlying health condition that, well, you know what, COVID doesn't really affect me, so I can still travel, or I can still do this, or it's not going to get me, so it's only going to get, people with. How important is language when we're talking about a crisis like we are in?
Well, I mean, that language is really infuriating. I gotta say, because that's a violation in many ways of human rights. Because what that language is saying, in some ways, where we've seen it to the extreme, is these people were going to die anyway. We saw some of that language of politicians and policymakers tweeting that in March and April, saying, that was the whole, Barrington debate. Well, we don't really need a lockdown. We don't really need to do anything because it's only really affecting people in long-term care homes, as if they're not family, they're not human beings, they're not loved ones to anyone. And, is it really worth the economic pain to save these lives? Or, people who may have passed away were already sick. So, how bad is this pandemic by who it chooses and who gets affected? And to me, that has been, just enraging.
Maybe this is a great segue into the mobile health clinics, like bringing health to you. Explain to me, we know that a lot of people who are homeless, who might be faced with addiction and other challenges, they don't go to hospitals. They don't trust doctors. They don't trust walking into an emergency room or whatever it might be. So is that the reason for, mobile health? Like, explain to me how a mobile health clinic works for the people that we need to reach the most.
Yeah, I mean, I think the one thing to start with this, and we're going to hear, I think, a lot of this coming up, is about that issue of mistrust with certain populations and the healthcare system and hospitals. And I really want to start from the position that mistrust is rightful. I think we have not talked about, been open about the histories of institutional violence towards certain populations, Indigenous populations, Black populations, and brown populations, about the horrors that the system has imposed on people, the experimentation, the type of care that people have received. And if you're from a certain community and you have a certain history and you've heard stories from your family, or what we've seen play out in the pandemic of people being neglected and dying in hospitals because of systemic racism, with no other excuse than that, than what it was, how can you expect people to say, well, we'll come trust the hospital, come trust us now with vaccines, or come trust us with whatever care is to be delivered? So I think that it's really important on the trust conversation that this is something that the healthcare system, in my opinion, needs to build back, needs to be open and own the history and the violence. And again, it predates so many of us working in the system or coming through the training, but that intergenerational trauma persists. And rightfully for people who have to live with that and wear that and have the burden of what the system has done. So I think to that point, and we've seen this as well so much with the harm reduction space. I mean, I wanted to get that to your point about, what does it feel like when people are saying it's only certain people who die? I mean, think about what people in the harm reduction space and activists and people, the thousands of people we've lost to an avoidable issue around the overdose deaths, of the lack of action from government, of the criminalization of substance use, and even just thinking about how long we've had such problematic language as we sort of started the conversation, from substance abuse now to substance use, but really we're about addictions. And again, this onus on folks as frequent flyers, as trying to come in and use the system for their own gain, as opposed to thinking about how we've underserved so many populations and we've underserved those patients in front of us. So I think it's just to be rooted in that history, in the fact that also this isn't new with the pandemic. There's been a pandemic of overdose deaths, and we've not responded the way that we should as a system and as a public health system to ensure those lives could be saved because of that intersection with racism and discriminating people living in poverty. And so I think going to the mobile possibilities, again, we've seen also, I think, Tamara, it's really important to frame and to start from the fact that in the pandemic, the innovation of testing and outreach was led by community. I mean, hospitals were able to innovate and trying to ensure that if you did have COVID, there'd be ways to improve the treatments and have higher survival rates. But some of the true system innovation, most of that true system innovation was actually being led by community in going out to various neighborhoods, having the trust that's already been there to ensure people could get tested. Because as we talked about the barriers, coming to the Toronto Western to get a test, if you don't have paid sick leave, if you can't have access to booking online, if you don't have a primary care physician, all of those things created barriers, even though there was no direct copay of, $2 or $3 or whatever it would be. There was zero. And so people would say, again, back to the history, we have a universal system. It's free for everyone. And it's not. And COVID has shown that. The way hospitals try to deliver care shown again that there's various barriers for different people. And I think that's one of the biggest pieces that really started to play out through the pandemic. And it was communities going out into neighborhoods, into buildings, apartment buildings, various areas, church parking lots to say, here's access to tests. Here are the wraparound supports you need. Or being able to answer questions that people have about COVID, about the test, establishing that trust that would never have happened in an emergency department in a hospital. And so I think really where the mobile unit, and obviously with Parkdale Queen West Community Health Center as primary partner and leading so much of this, is how do you get those supports out to people in communities, to people who actually don't make it into an emergency department, not just because of mistrust, but because of how poor their health outcomes are, whether that's about the overdose crisis, whether that's about COVID. So we've seen emergency department volumes really drop through COVID because of people's fear of coming in. But what has happened? These people who then can't even access the emergency department. And this is where I really hope, and no pun intended, of the mobile unit being one real vehicle to start to see ways that we as a health system can go out to where people are at, where they're at in their lives, and better respond and accommodate the supports that they say and they feel that they need.
Yeah. And again, it'll have to be built on trust, like you said, right? To basically start again with that trust that when you see that mobile unit, you know that you can trust them. You know those doctors are there to help you.
Yeah.
And that takes time too, doesn't it? It really takes time.
Yeah. And I would just say the one thing that's again, it's also not just about the doctors, right? Like that thing is we have, again, in our system, we have this bias that things are physician-centric or even nurse-centric, but look at so much of what we've seen, some of the best healthcare delivery has come from shelter staff, harm reduction workers, peer workers, people that have trust with these communities, that they trust them. And that's the concept for us of flipping the notion of health and health delivery, that it's not all going to be about what I may or may not be able to prescribe and come in. And if you don't actually have community workers, community leadership leading this, driving this vehicle, this bus of where it needs to be and responding, we're not going to see that trust no matter how long it takes. So I think that's one part. Is we talked a bit about some of the hierarchies and how we can start to see a more equitable delivery system. This is part of us having the humility as a hospital to say, we can't be driving this thing alone or driving it top down in neighborhoods and expecting us to be part of serious change.
Before we, I could talk to you for about a week, I think. Tell us, when we do this podcast, we really look for ways that we can give back and, so that we can help other communities or with a little bit, right, across Canada. And one of those ways is we make a donation on behalf of our guests to something that is meaningful to them. And we want to donate, or we'll be giving, I should say, $500 to Sound Times in Toronto. Can you tell us what Sound Times is? Yeah. Why you chose them?
Well, one, I've been fortunate to be able to work with their team clinically. They've got incredible leadership there of Lana Frado, who's running the spot for decades. When you're looking at what they do, they've really been there as a place to support people in the toughest times of their life. It's a real community, incredible. We're talking about the importance of health outcomes of the community workers, community health workers there, the case managers. It is inspiring to see just everything that they're trying to do to help support people either come out of the prison system or have been experiencing homelessness, or are in the shelter system, but looking for the ability to have these drop-in supports. And all of these things, again, we talk about social medicine. None of this is new. Sound Times has been doing this for decades.
Right. Well, they sound amazing. I'll be looking them up after this conversation for sure. So we will be giving them $500 on your behalf.
Very, very
And they sound like an incredible place. So we need to, I think that we can both agree that we need to rethink our, traditional ways of providing healthcare. Um, Something that I learned, Andrew, that I had no idea about, and I can't believe I never even made this connection. I read an article in the paper a couple of months ago about a woman who is addicted to drugs, and she has a bad hip, and she needed a hip replacement surgery. Young woman. And she couldn't get she was in extreme pain. So of course, this doesn't help. When you're in extreme pain, you need pain relief. And I mean, we all know this. She couldn't get her surgery because she didn't have a home to recover in. And I never made that connection. I truly thought that if you need a serious surgery like a hip replacement, that you could recover at the hospital. And then you would have I didn't know you didn't have access to that important surgery because you don't have a home to recover in. That is pretty broken.
Yeah, and I can't comment on the specific case.
Yeah, obviously, but
they're there. But and this is, again, we talked about the intersection of things coming into play. Someone who has a substance use disorder, using various narcotics or opioids, and then being denied potentially pain help being in the hospital or denied surgery. Again, this all is wrapped around the discrimination we have around certain populations. And it's not uncommon, in my own training, of where if you're in the emergency department, you've seen this person come in 4 or 5 times, you'd be trained to sort of say, again, this is a frequent flyer. They're back, either they're drug seeking, they want something. And it really impacts the way you, A, most importantly, treat people, but B, your clinical judgment in ensuring, does this person have a broken hip? Is this person in with a potential blood clot or cardiovascular issue that you're missing? And that is also one piece we haven't talked about, that the systemic discrimination, the way that we have a pejorative view of people in our system, really, really impacts the quality of care. I mean, you cannot have a high quality healthcare system without health equity being central as a pillar. And it's in some of the ways we've talked about, of those sort of more upstream barriers. But even when you get down right to that clinical interaction, the bias, the discrimination, the racism can really impact the decisions that are made. And again, I'm not able to comment on what happened in this case specifically or where, but we've seen these sort of play out, thousands of times. And we've seen it play out in COVID, where people are able to record it, or we see it all the time of, again, why certain individuals and certain patients don't want to come back to certain emergency departments.
Right. I think what I wanted, is when you're homeless and you don't have a home, that means you have nowhere to recover from anything. Well, whether it be a common cold, or whether it be cancer, or whether it be a surgery of some sort, or COVID. When there's a COVID exposure at a homeless shelter, what happens? And we had a case of that in BC. It's happened. So I guess my point is that it brings us all back to how we started this conversation, right? About it's not equitable. It's not, I have a home to recover in. You have a home to recover in. But somebody 5 minutes from here doesn't have a home to recover in. So what happens when they get COVID? What happens when they need surgery, right? And it all comes back to what you said about we can't have this hierarchy.
I mean, I think the whole system, it's backwards, right? To your point. I mean, it's just backwards. I mean, we are okay ordering MRIs for individuals, which in some cases has high clinical, rationale, sometimes to not, which is thousands of dollars. But we have this aversion as a society to ensure everyone has housing, everyone has access. I mean, to me, it's so backwards. To your point, you cannot have health in this country without housing, whether that's about being able to take your medications. So, to your previous question, I mean, saying how broken it is, it's broken and backwards. I mean, we're okay to also, and I think this is a great virtue of our system, that we don't have private healthcare hospital stays. If you are sick, you need to be admitted to hospital. No one's asking for your Visa card. Nobody's footing you with a bill when you go, and people aren't saying you can't stay here because you don't have the right insurance or the right sort of financials. Mm-hmm. But we're okay to do that, and we should. And that can cost tens of thousands of dollars, depending on why someone's admitted to hospital and has a hospital stay. But we have issues about being ensuring through COVID, for example, of ensure everyone has access to a hotel room, where everyone has permanent housing going through the pandemic, which is, a human right. To your point, this is a violation of human rights, which is, to me, the most compelling part of this. To your point of it, it took a pandemic and COVID to say, how is the shelter system, or a place where people do not have the space when the messaging has been physically distanced and you can't do that, how does this ensure and uphold human dignity? Well, it doesn't. And then to your point about the costs, it's also not a cost-effective system. So if you're an economist or you're a philosopher or you're a pastor or human rights activist, all four, which would be very unusual in a bar pre-COVID, would have completely agreed on what needs to be done. And we still haven't done it. So I think, this is something where we have to see the change. And we've seen to be fair, we've seen a lot of things mobilize in the pandemic that took years to happen before. There was the Rapid Housing Initiative of more people getting access to hotel recovery sites or various housing arrangements across the country. But if we don't actually transition these interim supports into lasting solutions, we will continue to have a backward system where people who are experiencing homelessness live decades less than you or I or anyone in sort of the neighborhoods that we're in. And I think the other aspect to this is we need to ensure we do this now, because we talk about human rights. A cynic could say, well, there's been government action because all of a sudden people who are living in shelters were seen as vectors of disease. And so people want to ensure that wasn't spreading. But when COVID's gone, are we okay to go back to the way we accepted that people have to sleep outside, that people can't trust the system they're in a shelter? And so I think this is, to me, what is so crucial, is that we ensure on human rights that we are moving forward with the policy change that we need. And that's housing for all. Mm-hmm. And housing first, and that's housing is health. And if we don't have those pieces in place, we're not going to move forward in the kind of health equity that we need. I mean, the other piece I'd add to that too is you don't need a fancy clinical judgment score of knowing who, when you discharge from hospital, is more likely to come back, whether it's the person who doesn't have a stable place to stay or is out housing, that's going to trying to find a spot in a shelter system, to someone who's going to an affluent neighborhood, who's got someone picking them up, a driver, and has got a personal trainer at home, and ensuring that they're getting all of the right supports and things in place. Mm-hmm. So again, we've known this. We can make it more sophisticated if we want, but I hope COVID has actually just really, as you said, ripped the curtains back on what needs to be done.
Fascinating conversation. And like I said, I could talk to you for a week about this. I have so many more questions for you, but we do have to wrap up. But, for anybody listening who's, just your average Canadian, I'm your average Canadian, what can I do? How can I help? What do we need to do to what can we do to change this? Like, I feel like sometimes it's easy to say, oh, write your MP or that doesn't seem to work. Do we need to hear from more physicians and more healthcare workers? Like, do they need to, what can we do?
Yeah, I mean, one, I actually think that the quote unquote, like you said, average citizen, which I still,
I know. Not a poor choice of words.
No, I mean, fair enough. I mean, the general public. I mean, I think to me, I wouldn't abandon the writing campaigns. I think they'll be effective, or however has been done. But I believe the change is going to come from the public, and I think there's been physicians and healthcare workers and nurses and social work who have really advocated for decades on these issues. And obviously that's been inspiring for me coming up in that fold. But I really believe the true change has to be led by the public and community. And I guess I would say, there has been this real sense of unfairness, of how unjust things have been through the pandemic. And we've seen this with systemic racism. We've seen it with who has been able to survive in this pandemic, who has been able to stay safe, and the kind of work environments people are in. I would not lose hold of that violation of unfairness. I would keep that notion, that real visceral sense that people now have of how unjust our society is, how unfair it is on issues that are no fault of other people, of people in certain communities, of other individuals, that they know and have seen how this has all played out. People didn't know before the pandemic. I think that has really come home for people. And please, please don't lose that, and let that drive you and channel the work and advocacy that you feel best. If that's writing your MP, that's great. If it's, trying to come up with a coalition to do something else with your neighborhood, amazing. If it's to donate or give to a charity of your choice, all that is so helpful. And if we just allow ourselves to go back in this lull of complacency, we won't see these changes that, again, going back in the arc of this conversation, we have to honor those people we've lost. And so please don't lose that sense of unfairness, however it is that you see that this makes sense to you, whatever aspect, to your point about disability or race, poverty, and gender that have really been seen to how disproportionate and how unfair it has been, whatever speaks to you or all of it, please don't lose that once, we feel that, we're through the woods, because the real work and the real fight is ahead.
Thank you so much. Truly. Thank you for everything you do. Thank you for taking the time to help us understand this. I really, really appreciate it. You're on Twitter. You are Dr. Andrew B. So Dr. Andrew B. Is that right?
Yes. Yes. Somewhere
in that. I'll find you on Twitter. I will find you on Twitter and at Dr. Andrew B. And thank you so, so much. I really, really, really appreciate you taking the time to help us understand more of this. And I appreciate all the work you're doing.
Thanks so much for all your interest and all your support. Thanks so much, Tamara.
Thanks for listening to another episode of TELUS Talks with Tamara Taggart. Be sure to subscribe so you can join us every Tuesday for another conversation. You can also check out our website, telus.com/podcast, and subscribe to our YouTube channel at TELUS Talks.